Hey, my name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 4 of this cardiology series, where we're going to be talking about heart failure. Um, Hopefully you find this video useful, and if you do, remember to like, subscribe, and leave a comment. So without further ado, let's get straight into it. So like always, we need to talk about some definitions. So heart failure, simply put, is the heart's inability to pump adequate blood and therefore oxygen to peripheral tissue and organs in the absence of mechanical obstruction. Half of all patients will have a preserved ejection fraction. So we need to talk about this term ejection fraction, and we can use various things in order to calculate it. So first of all, we need to work out something called the stroke volume. The stroke volume is the volume of blood ejected from the left ventricle per uh, each systole, so per ventricular contraction. And to calculate this, we need to know the end diastolic volume, which is the volume of blood within the left ventricle at the end of diastole, so at the end of cardiac relaxation. And we also need to know the end systolic volume, so the volume of blood which is remaining in the left ventricle after systole, so after contraction. And then we can work out the ejection fraction, which is a percentage, and you work it out. So you have within brackets the stroke volume, which we've just calculated, divided by that end diastolic volume, close the brackets, and then all times by 100 to get that percentage. Normal ejection fraction in males is 52 to 72%. In females, it's 54 to 74%. And then a reduced ejection fraction is less than 35 to 40%. And then we have some other definitions here. So we have cardiac output, which is stroke volume times heart rate. And then from this, when we've calculated the cardiac output, we can work out an estimate of the patient's blood pressure, which is cardiac output times total peripheral resistance, also sometimes known as systemic vascular resistance. So it's basically the resistance within the blood vessels. And then we need to look at this term here, congestive, because heart failure is sometimes called congestive heart failure. And this relates to the congestive symptoms due to the altered pump mechanisms. So you can have congestion within systemically or within the pulmonary circulation. I'm going to talk more about these symptoms in a bit more detail later in the video. And just remember to, really understand your physiology, really get a good grip on your physiology, because then that'll help you to understand pathophysiological processes. So let's talk about the classification of heart failure. So heart failure can be classified anatomically. So you can have left ventricular failure, right ventricular failure, or both of the ventricles can fail. You can have biventricular failure. You can classify it by ejection fraction. So the ejection fraction can be preserved, typically seen when there's diastolic dysfunction. So dysfunction in ventricular relaxation, or there can be a reduced ejection fraction. This is typically due to systolic dysfunction, so a problem with the actual contraction of the ventricle during systole. Heart failure can also be classified in terms of time course. So it can be the deterioration can be acute, so minutes to hours, or it can be more chronic. So the symptoms, this is where symptoms are stable for 1 month despite optimal management. And I just want to talk a little bit about what happens when you have hypertension, for example, because in hypertension there's increased systemic vascular resistance, and that means there's an increased afterload. So the afterload is essentially what the left ventricle has to overcome in order to eject that blood from within the ventricle. So it's basically what the muscle layer has to overcome by contraction to eject that blood from the ventricle. Um, so essentially what you have the heart trying to compensate for this, and you can have this term called cardiac remodeling, what we need to discuss. And cardiac remodeling is where the muscle layer of the heart changes as it tries to adapt to this um, to the hypertension in this example. So we need to look at the wall thickness because various things can happen. We can have eccentric hypertrophy, where the ventricle becomes dilated and the overall muscle layer is thinner, or we can have concentric hypertrophy, where the muscle layer it's thickened and the actual size of the ventricular chamber is smaller. And we're quite worried about eccentric hypertrophy because in that case we're going to lose that ejection fraction. It's going to decrease. It can initially be maintained when you have concentric hypertrophy, but then it's eventually going to decrease. And concentric hypertrophy can then also result in eccentric hypertrophy. What we have going on essentially is we have an increase in size of the cardiomyocytes, the cells which make up the muscle layer, but we're not having really an increasing number. So the strength of the contraction isn't actually increasing. So you might have more contractions happening, so you might have hypercontractility, but the contractions aren't necessarily as forceful. And over time, the heart becomes more globular, less elliptical, and the overall muscle layer is thinner. And this leads to further wall stress, leading to further wall stress, and you have this dilated ventricle. And like I said already, whether the ejection fraction is preserved or not depends on the type of cardiac remodeling. It's worth also mentioning when we have pulmonary hypertension, there's an increased afterload. This is because of the increased resistance within the pulmonary vessels. And in a similar process, we'd have hypertrophy and then dilation of the right ventricle. And this is when we're looking at right ventricular failure. So let's talk about some risk factors which can lead to heart failure. So we have our cardiac risk factors such as ischemic heart disease, hypertension, cardiomyopathies, valvular heart disease, pericardial disease such as pericarditis, which can be associated with pericardial effusions, etc., arrhythmias, and congenital heart disease. Um, and then this is just basically a schematic about the process when, say, for example, if a patient had an MI, what some of the complications are, and then how this leads to pump dysfunction, so dysfunction of the myocardium, which then leads to a decrease in cardiac output and systemic perfusion. And then this process happens, more subacutely, you can end up with heart failure. So I use this diagram actually in my last video on MIs. So if you haven't seen that already, make sure to check it out. And then we have some other risk factors. So volume overload, which can be seen in chronic kidney disease or nephrotic syndrome, obesity, and then certain drugs such as alcohol, cocaine, NSAIDs like ibuprofen, beta blockers, and calcium channel blockers. Okay, and in hypertension, for example, because you have that increased systemic vascular resistance and an increased afterload, you have compensation by the myocardium, and you get that cardiac hypertrophy to try and maintain the cardiac output and resist that increase in pressure. But unfortunately, these mechanisms can be counterproductive and lead to further problems. And in terms of hypertension, you have the baroreceptor reflex as well, and that eventually it shifts to consider a higher blood pressure as normal. And sometimes the kidneys can undergo this process called pressure natriuresis to counteract the hypertension, which is essentially where you have an increased excretion of sodium and therefore water. Sodium and water are quite closely linked in terms of movement together. Okay. And then cardiomyopathies, like I mentioned here, I'm going to talk about them more in future videos. But the one related to alcohol in particular, chronic alcoholism, is a dilated cardiomyopathy. Whereas if you looked on an echocardiogram, you can see dilation of all four of the heart chambers, and in that you have systolic dysfunction. So the myocardium of the heart isn't able to contract properly. I'm going to keep reiterating that point about diastolic and systolic dysfunction. Okay, and then in terms of CKD, how that kind of how that kind of leads or can lead to heart failure is because you have a loss of albumin in the urine. Therefore, you're going to have lots of fluid retained in the tissue space, which leads to fluid overload because you can't really maintain the oncotic gradient within the postcapillary venules isn't maintained anymore. Okay, and the kidneys in CKD they lose their ability to excrete cardiotoxic substances, and these can further damage the heart and kind of fuel this pathophysiological process. Okay, and then I've already mentioned about alcohol, that's related to dilated cardiomyopathy. So let's talk about the Frank-Starling law. So this was discovered by Otto Frank and Ernest Starling, and Otto Frank investigated changes in end diastolic pressure with varying volumes in frog hearts, and Starling looked more at mammalian hearts, and basically how varying the effects of temperature variation on cardiac output. So let's talk about. So I've got a flow diagram here, which basically outlines the Frank-Starling law. But what it is as a definition, in simple terms, is the more the heart chambers fill, the stronger the ventricular contraction. Okay, so that's what it is. So initially, what we have first is we have a rise in central venous pressure. So central venous pressure is the pressure within the vena cava, and it's used to estimate the preload. So the heart chambers fill. So let's talk about the ventricles. So the ventricles fill and stretch, leading to formation of multiple actin myosin cross bridges. As more cross bridges form, this requires more energy for the cross bridge cycling process. The muscle fibers stretch to an optimum length. After that, the stroke volume and cardiac output decreases. So we have this optimum length of the fibers in terms of the cross bridge cycling. After that, stroke volume and cardiac output is going to decrease. But what I'm trying to say is, initially, when you increase the preload, so when you get more blood returning to the heart, the larger the volume you have, the more that myocardium within the ventricles is going to stretch, and the more forceful that contraction is going to be. But after a certain point, the muscle fibers become overstretched, and it's not optimal anymore, and therefore the stroke volume and therefore the cardiac output are going to decrease. I hope that makes sense so far. So let's talk about the Frank-Starling law related to some pathophysiology, the underlying pathophysiology of heart failure. So what you have is a reduced cardiac output, hence reduced circulating blood volume. So because there's reduced renal perfusion, and therefore you have sympathetic stimulation of the kidneys, which causes activation of the renin angiotensin renin-angiotensin aldosterone system. And therefore, because of that, you have reduced urine formation and increased water and sodium reabsorption. You have an increased circulating blood volume, which helps to maintain the cardiac output, like we just talked about just before, about increasing that preload to try and increase the strength of contraction and therefore the volume of blood ejected from the heart. But however, an increase in central venous pressure leads to systemic and pulmonary edema. And we also have an increased hydrostatic pressure within the capillaries. So in the systemic capillaries, we're going to end up with peripheral pitting edema, as opposed to non-pitting edema, which you might see in something like lymphedema. And then within the pulmonary capillaries, we're going to have this pulmonary edema forming, which is going to lead to symptoms such as exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea, which we're going to, hopefully get a grasp of very soon. I'm going to talk about them symptoms. Right. So essentially, you also have this thing called neurohumoral. So basically, neurohumoral mechanisms, which act to basically to try and maintain that cardiac output. And this happens via activation of sympathetic nerves from the medulla oblongata, and from baroreceptors in the aortic and aortic arch and carotid sinus. And the main goal is to produce increased vasoconstriction of peripheral vessels, so arteries and veins. And then sympathetic nerves also cause tachycardia. So you're going to have an increased afterload, and therefore reduced stroke volume. And then when you have an increased, you're going to increase preload. This is going to lead to basically relates to that increased central venous pressure, therefore resulting in systemic or pulmonary congestion, hence the term congestive heart failure, leading to that edema. So hopefully that makes sense as well. So this is also something to be aware of, especially for exams. This is high output cardiac failure. So it's where the heart is unable to provide sufficient blood for the body's demand, basically. And what you're going to have a higher cardiac output than normal, combined with a reduced systemic slash peripheral resistance due to an increased peripheral demand. So there's an increased demand for oxygen. Okay, and it's just before I get into this diagram, the normal cardiac output is roughly 4 to 8 liters per minute. In a high cardiac output failure, the cardiac output is greater than 8 liters per minute. Right, so what we have is so we have an excessive decrease in systemic vascular resistance. I'm going to pick out a few conditions as well where this applies. This is just a general schematic. And we have an increased oxygen consumption. So we have increased left ventricular emptying, an increased heart rate, and increased left ventricular contractility. Therefore, an increased cardiac output. But there's a persistent decrease in systemic vascular resistance, which leads to reduced renal perfusion and activation of the RAS system, which leads to fluid retention, and therefore this high output cardiac failure state. Or we can have chronically increased preload, which increases the filling pressures and also results in this high output state. So let's look at some examples. So in thyrotoxicosis, there's hyper contractility of the myocardium because of the increased circulating T3 and T4. You have volume overload, an increased heart rate, and you have a reduced systemic vascular resistance due to the increase in waste products of metabolism. So you're going to have more CO2 being produced via um, aerobic respiration in tissues, and CO2 is known as it's a peripheral vasodilator, so hence why you have this decrease in systemic vascular resistance. But the hypercontractility is due to the T3 and T4 stimulating that myocardium and causing that increase in heart rate. And then some other examples what we have. Sometimes you can have arteriovenous malformations and fistula, and essentially what you get in that, you get bypassing of the arterial and capillary circulation. So you have blood going, so it's basically it's yeah, bypassing the arterial circulation and going straight into the veins. The veins are able to accommodate larger volumes of blood. So you have increased venous return to the heart and increased myocardial wall stress. And you have a decreased overall systemic vascular resistance. So there's less blood within the arteries and the veins are in a lower pressure state. And then one more that I want to just talk about quickly is in lung disease. So when you have type 2 respiratory failure in particular, you're going to be in this CO2 retention type state. And I've already mentioned that CO2 is a peripheral vasodilator. So you're going to have that reduced systemic vascular resistance because of the increase of CO2 in the peripheral circulation. And then you're also going to have this the right-sided heart strain because of the underlying lung disease. And when you have the right-sided problems of the heart due to the kind of isolated lung disease, this is sometimes known as cor pulmonale, and this can result in, it can be a result of lots of different lung disease. So what we have here, we have a good summary table of some of the clinical features of left-sided heart failure, and right-sided heart failure. I've also included some other features. So the ones I wanted to talk about in particular were related to left-sided heart failure, so dyspnea, orthopnea, paroxysmal nocturnal dyspnea, are the main three I wanted to talk about. So paroxysmal nocturnal dyspnea is essentially breathlessness after 2 to 3 hours of sleep, because basically patients with heart failure can have bilateral ankle edema, so lower limb edema, and during the night when they're laid on their back, this fluid gets reabsorbed into the systemic circulation, and you have increased pulmonary congestion, leading to this sudden shortness of breath and disturbed sleep pattern. Orthopnea, which is quite a late sign, is immediate, so it's immediate shortness of breath on lying down, which is improved, pretty quickly by the patient sitting back up. And the reason is because when the patient sits back up, the fluid is going to move due to gravity down to kind of um, the lower areas of the lungs, particularly like the costophrenic angles, that region, and then it means that the upper lobes of the lungs, the ventilation is going to be improved, and they can therefore be perfused essentially. And dyspnea, so initially this is on exertion, so after activity, and eventually this can progress to being at rest. Okay, and then we have some other features here. But because like, oh, for example, when we have this sympathetic nervous system response to try and compensate for the problems, that's going to lead to mydriasis, so dilation of the pupils. Um, Other things, patients might look pale grey. They might be cyanotic, so the skin might have a blue tinge. Um, and Yeah, so essentially, there's some of the clinical features. So we've got here someone who's quite short of breath. Um, we've got here a yellow sclera, which is called icterus, and that can happen if you've got a right-sided problem. You're going to get blood going back into the inferior vena cava, and then you're going to have this congestion within the hepatic circulation, um, leading to damage and leakage of bilirubin, and then the bilirubin's collecting within the sclera of the eye. Um, that's why the sclera is yellow. And then this is just an example of the mydriasis, of the dilated pupils. So let's talk about left and right heart failure in terms of physical examination. So in left-sided heart failure, we have the observations. So you can have tachycardia because of this, because of the sympathetic response, tachypnea. We have a reduced urine output, and a reduced level of consciousness, and this is typically because the kidneys and the brain are perfused less. And we've already mentioned about the cool extremities and blue tinge to the skin, the cyanosis, because of the reduced um, oxygenation of the blood. And then on inspection, patient might be sweaty. Diaphoresis is a term what I've mentioned before. The patient's sputum might be blood tinged. It can kind of Patients might have a cough and they bring up this kind of um, frothy pink sputum. And then on palpation, um, if the apex B is diffuse, that could mean the ventricle is dilated. But if it's sustained, if it's kind of similar, you might have more of a hypertrophic ventricle. It could have um, undergone some concentric hypertrophy. And then in terms of auscultation, we have could be some additional heart sounds. There could be an S3, there could be an S4, be a loud P2, a wheeze, or we could also have some pulmonary crackles. An S3 is turbulent flow into a dilated ventricle. Um, so turbulent flow into a dilated, sorry, forgive me, a dilated compliant ventricle. So this can be normal in pregnancy, athletes, or sometimes people under the age of 40. Um, when you have an S4, the atria contract into a stiff, non-compliant ventricle in late diastole. That's what it's essentially due to. I've been on placement for quite a number of years now, and I actually haven't ever heard an S3 or an S4. A lot of doctors haven't either, so don't worry if you haven't. And then you essentially get a loud P2, so basically that's shutting of the pulmonary valve on the right side of the heart due to an increase in pulmonary vascular pressure. For example, if the patient had pulmonary hypertension, um, and then um, the pulmonary crackles. This is very important actually. They tend to be bilateral inspiratory crackles. Um, But yeah, bilateral inspiratory crackles. That's a very important finding. What you should say you're looking for, particularly yeah, on physical examination. It's important in OSCEs too. And this is due to the pulmonary edema, particularly what you get in left-sided heart failure. And the pulmonary edema is transudative, so it has a low protein content. If you test it for LDH, that would also be low. So let's look at right-sided. So You have a reduced right ventricular stroke volume. I hope you understand that by this point in the video. Isolated right ventricular failure, typically due to this lung disease called col pulmonale, which I'm reiterating now. So similarly on inspection, you might have some peripheral pitting edema, raised jugular venous pressure, palpation. There could be some right upper quadrant discomfort because of the congestion uh, within the liver. You could even have some pain on the left side because of congestion within the spleen. You might have a right ventricular heave, which can be felt at the left parasternally when you have enlargement of the right ventricle, and that's due to the underlying hypertrophy. And then auscultation, you might have a loud P2, and this is just due to the pulmonary hypertension. So the pulmonic valve shuts with greater force. That's why you might hear this, or why P2 might be louder. Okay, so let's talk about some investigations. So we want to do a B-type natriuretic peptide. So BMP functions to decrease the release of renin. And when you have elevated levels of BNP, this is a sign of ventricular strain, and it's measured in picograms per milliliter. And if the levels are elevated, greater than 2,000 picograms per milliliter, you have to do an echocardiogram 2 weeks following that measurement. And this is essentially just the normal mechanism of some of the natriuretic peptides. So ANP, which is atrial natriuretic peptide, and BNP, which is, like I've mentioned, brain natriuretic peptide. Other investigations, you need to do some U's and E's, HbA1c, particularly if you've got diabetes, LFTs, TFTs, and FBCs, remembering them causes of high output cardiac failure. They all need to be investigated. An ECG can be a good investigation because that can indicate, there could be signs of a previous MI, such as pathological Q waves. There could be arrhythmias or signs of ventricular hypertrophy. So look here, we have the tall and thin QRS complexes in this region here. So this could indicate that there's some left ventricular hypertrophy. An echocardiogram. So for medical school, understand that you have to understand that an echocardiogram is important, but you don't need to worry too much about the features that the cardiologist might look for. I'm going to mention a few of them anyway, just for your own reference. And then other investigations we can do a chest X-ray because we can look at signs of can look for early and more later signs of pulmonary edema. And we might do a urinalysis and then also some peak flow and spirometry if we thought there was an underlying respiratory cause of this. From the ECG, you can sometimes have a left ventricular strain pattern, which is where you have ST depression, T wave inversion, and increased QRS voltage. So the QRS voltage just means the height of the QRS complex. You can also have broadening of the QRS in V5, V6, 1, and AVL. So they're leads which look at the lateral, the left side of the heart. So I said I'd talk a little bit about the echocardiogram. So I'll do that now. So if you had some systolic heart failure on the echo, you'd be able to observe a reduced ejection fraction. If it was diastolic, you'd have this abnormal ventricular relaxation, or stiffness, in other words. And then common features, what you might be able to see, or determine from the echo. You might see an increased end diastolic pressures, increased systolic wall tension, and You might have some left ventricular enlargement, or it could even be right ventricular enlargement, and something called paradoxical septal motion bounce. All right, so this is quite an important slide where we're looking at a chest X-ray in heart failure, and I'm going to walk you through some of the features. So first we have cardiomegaly, and cardiomegaly means um, an increased size of the heart, and what we actually have is an increased cardiothoracic ratio. So the heart on this should typically take up less than 50% of the width of the thorax, and you can only really determine the cardiothoracic ratio using a PA X-ray, because when you do an AP X-ray, the heart appears larger than it is in reality, just because of the shorter distance between the X-rays and the patient, because the heart's quite an anterior structure within the chest, structure. You can have cephalization of vessels, and essentially why this happens is because there's a diversion of blood to arteries in the upper lung, which are less compressed. And it basically represents an increased left atrial pressure, and is quite an early sign of pulmonary edema. And then we have a few signs here. So we have perihilar haze, kind of around here, peribronchial cuffing, which isn't actually labelled on the diagram. And basically all peribronchial cuffing is the bronchi appear quite almost ring-shaped when viewed end-on. But the one I want to talk about is the curly B lines. So the curly B lines are here. I think you can just about see them. And this is basically when you have fluid in the interlobular fissures near the costophrenic angles. So they're only roughly, 1 to 2 centimeters. And then we have pleural effusion. That's because of gravity. Fluid is going to accumulate in these spaces. And the term we sometimes use is blunting of the costophrenic angles. So I can't actually see any visible pleural effusion on this particular film. Maybe there's a little bit on this side, but here you can clearly see that the costophrenic angle sharp hasn't been blunted. So it's something to be also aware of. And then lastly, we have something called an air bronchogram. And this is a very late sign of pulmonary edema. So you have air-filled bronchi visible against fluid-filled alveoli. So the bronchi um, will appear black, and then the alveoli, because they're fluid-filled, they're going to be more radio-opaque, so they'll appear kind of white in colour. And you can't particularly see this on this chest X-ray, but I suggest you have a look at that as well. You can probably Google some good images of that. So, in order to stage heart failure, we have the New York Heart Association, which grades the severity of the functional limitations in patients with heart failure. And this is just kind of for your own reference. It's something you can have a look at in your own time. Otherwise, I'd just be reading off the screen. So, in chronic heart failure, lifestyle modification is very, very important. Like with anything, it's also always something, an issue what should be addressed first. So things what we might consider advising to patients include smoking cessation advice, reducing the amount of sodium a patient has in their diet, so a low salt diet, and that's just to prevent fluid overload, because remember how water always follows, it follows sodium. They're very, they're linked together. want to try and reduce the amount of alcohol someone's consuming because it's associated with an increase in blood pressure and increased risk of arrhythmias. Exercise regimes such as supervised cardiac rehabilitation. I talked a little bit about cardiac rehab in my previous video. Travel. Some patients might require in-flight oxygen or extra support. And symptomatic heavy goods vehicle drivers, they can't drive if they have, if they have symptomatic heart failure. In terms of sexual health, pregnancy in particular can worsen heart failure because you have an increased blood volume. And then another important point is PDE5 inhibitors. An example of one of them is Viagra, is not recommended to patients with heart failure. And I talked a little bit about this in the previous video about MIs. It's always important to assess the patient's mental well-being, see how they're doing, from a biopsychosocial perspective, and refer them, for any further assessment or appropriate treatment, if necessary. So, in terms of chronic heart failure, let's look at some pharmacological management. So first line, we can use a beta blocker such as bisoprolol, carvedilol, or nebivolol, and an ACE inhibitor. And what these do, they reduce ventricular strain and help to prevent that process of cardiac remodeling. Okay, and with both beta blockers and ACE inhibitors, you start at a low dose and then you titrate up depending on the patient's response. So ACE inhibitors, just something worth noting, they're contraindicated. Patient has a history of angioedema, what you might be aware of. They're also contraindicated in bilateral renal artery stenosis, severe renal impairment, and severe aortic stenosis. And when you start them, it's always important to monitor that renal function. Patients can also suffer with a cough. In that case, you can look at starting them on a angiotensin receptor blocker, such as candesartan, and that can be useful in that sense. Beta blockers are contraindicated in sinus bradycardia, type 3 AV block, complete heart block, asthma, and also sick sinus syndrome if the patient doesn't have a pacemaker. It's very important with beta blockers not to suddenly stop them too, because that can increase the risk of arrhythmias. Okay, so let's move on. So we might also look at starting something called an aldosterone antagonist. So we have two. We have one called spironolactone and eplerenone, and these are essentially potassium-sparing diuretics. And when we use these, we want to particularly monitor the renal function because they're potassium-sparing, they can cause hyperkalemia, especially combined with ACE inhibitors, where a side effect of ACE, well, not side effect, but something resulting from the use of ACE inhibitors is hyperkalemia too. Spironolactone in particular can also increase the amounts of circulating estrogen, which can cause gynecomastia. And if there's any reported breast tenderness, the patient can be switched over to eplerenone. Right, third line. So we have quite a lot of different medications here. And all of these medications require specialist advice before starting. So first of all, we have a medication called ivabradine. This is also used in angina too. So you can I definitely talk about that in my video about angina. Can be used when a patient has a reduced ejection fraction less than 35%. And it inhibits something called the funny sodium channels in a concentration dependent manner, and it doesn't affect any other heart channels. So it's good in try in preserving and helping to preserve that ejection fraction. Um, the next combination of drugs is something called sacubitril valsartan. So sacubitril is a neprilysin inhibitor. So neprilysins normally break down natriuretic peptides, um, and valsartan is an angiotensin receptor blocker. Um, like I said, neprilysins normally break down natriuretic peptides. So if you have them being inhibited, there's going to be increased vasodilation, um, sodium excretion, and an increased GFR because you're going to help to offload some of the fluid. Um, and then we have hydralazine and nitrates, which are particularly useful in Afro-Caribbean patients. And we have something called cardiac resynchronization therapy, which I'm going to talk about it a little bit later on in the video as well. But that's particularly useful for patients with left bundle branch complex, a wide QRS, and it can be useful in patients with milder or even more severe symptoms, particularly when they have a low ejection fraction. Other pharmacological considerations. Patients need an annual influenza vaccine, a one-off pneumococcal vaccine. I suppose this links to the fact that when they have pulmonary edema, there might be an increased susceptibility to infections. And then a relatively new drug what's used is either dapagliflozin or empagliflozin, which are SGLT2 inhibitors, which are typically anti-diabetic drugs. Patients might take 10 milligrams once daily. Important things to note in terms of dapagliflozin: don't start it if patient's eGFR is less than 15. You need to warn patients about an increased risk of diabetic ketoacidosis if they have diabetes, obviously. A risk of syncope, so lightheadedness because of potential volume depletion. It's also an increased risk of UTIs. So think about in older females. And there's also a very small risk of something called Fournier's gangrene, which is gangrene of the perineal region. So someone can have chronic heart failure, but then there are certain factors which can lead to them having something called decompensated heart failure, where that ejection fraction suddenly reduces. And some of these factors, for your own reference, are worsening ischemia, an MI, there could be valvular dysfunction, infections, AF, electrolyte imbalance, um, all these different types of conditions here, such as anemia, thyroid dysfunction, diabetes, etc. And then certain medications can worsen the heart's function, particularly pioglitazone, which is a type of anti-diabetic medication. It worsens edema. It's also important to avoid other drugs such as macrolides, which prolong the QT interval, lithium and calcium channel blockers. So let's talk about the management of acute heart failure. So if someone's cardiac function deteriorates quite rapidly, how we're going to try and manage that? So you want to fluid restrict the patient and sit them upright to try and improve the ventilation in the upper areas of the lung. And obviously you want to fluid restrict them because you don't want to fluid overload them, and you might end up giving them, it might restrict them to 500 mils per day, and see how they get on from there. Secondly, you want to consider the use of a loop diuretic, such as furosemide, bumetanide. Typically, these are you give 40 milligrams intravenously for symptomatic relief. So they're not improving the long-term morbidity or mortality, but the mortality, sorry, but they're given for symptomatic relief to try and offload some of that fluid. it's important to monitor for signs of low potassium, hypokalemia, and hypovolemia, so signs of dehydration. And you can give these medications orally, and if you did, if you did, um, you have to you can take into consideration that bumetanide has a better oral bioavailability than furosemide. You want to try and maintain the oxygen saturations between 94 to 98%. Nitrates, you don't routinely give them, and sometimes you can give them in severe hypertension, if the patient's had an MI, or if they have aortic or mitral valve disease. In the absence of these, you don't typically tend to use them. The patient has signs of respiratory failure, so you can have type 1 respiratory failure, hypoxia due to that pulmonary edema. You might consider the use of something called continuous positive airway pressure, CPAP, to try and improve that alveolar hypoventilation. It's a method of non-invasive ventilation. If that's ineffective, then you might consider more invasive methods. If the patient was in cardiogenic shock, which could present with an increased heart rate and a reduced blood pressure, the patient might also look cold, pale, or have mottled extremities. Use things such as ionotropes. Beta-1 agonists, a good example of that is dobutamine. So that helps to increase, try and maintain or improve the blood pressure to maintain peripheral organ and tissue perfusion. And then you can also use norepinephrine if dobutamine is ineffective. There are also certain mechanical devices what can be used, such as a balloon counterpulsion device, which is it's placed in the thoracic aorta. I'm going to come back to that actually, or a ventricular assist device. Continue the regular medications, just be cautious. If they're on a beta blocker and the heart rate's less than 50, you want to stop it. And then opiates can actually cause an increased morbidity because they can cause bradycardia, respiratory depression, and can even precipitate acute heart failure in patients with cardiomyopathy. So we also have some non-drug therapies, that being revascularization is the first one. So revascularization means improving that perfusion to the heart if the coronary vessels are affected. Two ways in which we can do that is through percutaneous coronary intervention, which you'll be familiar with from the last video, or via a coronary artery bypass graft. Remember, you can take the saphenous veins from the lower limb, or you can also do a bypass using the internal mammary artery. And then we have something called cardiac resynchronization therapy. And for heart failure, we tend to use something called biventricular pacing. So we have a pacing device which sits subcutaneously under the left clavicle, and it has these leads which go into the right atrium, right ventricle, and left ventricle. And they essentially pace these different chambers. And then within the pacemaker, there could be something called an ICD, which is an implantable cardioverter defibrillator. This can detect any abnormal heart rhythms and deliver a shock to try and reset the heart, which is also very, very useful in heart failure too. Sorry about that. And then we can have also left ventricular assist devices, which is an example of what I have here on the right. So blood enters the left ventricle, it enters the device, and then it's basically an artificial pump which connects to the ascending aorta. and basically functions with the left ventricle to eject blood into the aorta and therefore into the systemic circulation, providing perfusion to the organs and tissues. That's typically for patients who aren't suitable for transplant. There can also be problems with transplant, such as a lack of donors, rejection, and problems with long-term immunosuppressive medications. So this is just a good diagram, what I thought you might find useful, where we have an example of cardiac resynchronization therapy, where we have the control unit / pacemaker. We have the leads coming out. The red is the right ventricular lead. We can see it goes down here through the tricuspid valve. That's going to pace the right ventricle. We have an atrial lead, which is green, the place where the SA node is. And then the blue lead is the left ventricular lead, which is going to go through the coronary sinus over to the left side of the heart within this tributary, and then it's going to help to pace that left ventricle. And that's that biventricular pacing what I was talking about. So bi mean both of the ventricles, but remember the right atrium is also paced too. The prognosis in heart failure. So 50% of patients die within 5 years of the diagnosis. And patients with a preserved ejection fraction generally have a slightly better prognosis. But do you remember that the preserved ejection fraction can then reduce based on that cardiac remodeling process, which eventually leads to reduction of that ejection fraction. But yeah, so I know that was quite a long video. Hope you found it useful. Any questions or any comments, feel free to leave some feedback, and stay tuned. And because my next video I'm going to be talking about hypertension, and yeah, that's everything. So I hope you enjoyed it, and maybe you've got something out of it. And I look forward to next time. So bye for now.